The physician who referred this patient asked that we see her urgently, and you can see why. She was a 62-year-old woman who had had mild hypertension in the past, but in the last month or so had developed increasing blood pressure readings, and also her blood pressure became labile as well. And the referral was initiated when her physician found a blood pressure at the top of the cuff, 300 millimeters of mercury systolic. And this was despite her being on this antihypertensive regimen that you see. She was on no other new medications, and in particular, she was not taking NSAIDs. Her blood pressure in the mornings were often quite low. As you see, 84 to 96 systolic pressure, and this would resolve if she was lying down, but she had presyncopal symptoms frequently in the morning. In the evening, her blood pressure was quite high, and this was associated with some visual difficulty. Blood pressures in the range systolic of 190 to 200, and this might be associated with tachycardia as well. And at this time, she often had symptoms, had a hot feeling in the head, throbbing headaches often accompanied these elevations in pressure, and in particular, she described a black curtain coming down over her eyes with this. Her husband and other observers noted that she looked ashen, she appeared like a ghost, but on one occasion, she was described as being intensely red in the face, so flushing. We were fortunate in that her husband was trained as an accountant, so he came to the clinic with her blood pressures recorded on an Excel spreadsheet, which he had frequently documented during the day, and this is what his data showed. As you can see, her blood pressure went up during the day, reaching a peak here in the early evening, and it was this point that she had symptomatology such as visual disturbance. However, the following morning, her pressure would be down again, and then that would be repeated again the following day. And she had an orthostatic hypotension with symptoms on this third day of observation. So this was her clinical state, and with these elevations in blood pressure, at the peak you can see that she had some tachycardia. And this pretty well correlated with her blood pressure up to levels maybe 160. She had mild hypertension, mild diabetes, which was not being treated. She was hypothyroid. She complained of chronic low back pain and also spasms and pain in her neck, and was anxious. The medications are, as you had seen, for hypertension. She was also on a statin, Tizanidine, and levothyroxine, and her TSH levels were normal. She was not a smoker, her alcohol intake was not excessive, and she was not taking cocaine. She had no family history of endocrine tumors. On exam, her systolic pressure was quite elevated, 186. She was mildly obese. On fundoscopic examination, revealed some copper wiring and AV nicking. Her exam was otherwise normal. There was no radiofemoral pulse delay. Her potassium was normal. She had no left ventricular hypertrophy on electrocardiogram and no repolarization abnormality. So these were the principal considerations when she arrived. Pheochromocytoma, baroreceptor failure, such as one can see after resection of paragangliomas in the neck, presented this way, autonomic dysfunction, There's a possibility some pathomimetic drugs may be seen, either factitious or patient unaware of the fact that they were inducing their hypertension, and withdrawal from clonidine. She had no evidence of primary aldosteronism. Her plasma norepinephrine was 799. Her norepinephrine was 902 in the urine. Notably, her plasma epinephrine and metanephrines were well within the normal range. Her data are superimposed on the data presented by Eisenhower, showing that her norepinephrine is in the high normal or low FeO range. Epinephrine is totally normal. And in the right-hand panel, her normetanephrine is well up at the top of what one sees in normal individuals. So one question would be, could a pheochromocytoma be associated with symptomatic hypotension? I'll put that out for the audience to discuss.
Okay, we've got Bob Carey coming to the microphone, please.
The answer to the question is yes. Hypotension and postural hypotension can be associated with pheochromocytoma. You would expect that if it were a straightforward pheochromocytoma, that the hypotensive episodes might be related to epinephrine release by itself, and particularly in the absence of a norepinephrine surge. I've seen several patients who had purely epinephrine secreting pheochromocytoma, and their symptoms and signs were they developed severe episodic hypotension, and they turned ashen gray, similar to the history of this case during those episodes. So with this case, though, with the metanephrine and epinephrine levels being normal, we have to think that something else might be going on. And we have to keep in mind that pheochromocytomas have the capability of secreting many various neuropeptides and vasoactive peptides. So there might be a concurrent release of these peptides with some of the catecholamine surges.
Okay, and another
Thank you,
comment.
Dr. Garry.
One more comment, please.
Yes, I was quite struck by the circadian variation that you described. And so one of the questions I would ask of the husband and of the patient is whether there was a pressure natriuresis at night. What was the frequency of nocturia, and could she have been volume depleted in the morning, accounting for her morning hypotension?
Yes.
And I also was struck by Dr. Otto Kuchel's description of some pheos that produce dopamine, leading to this type of labile hypertension with periods of hypotension. So those are my two thoughts thus far.
Okay, would you like to answer? I perhaps want to add to this amazing regularity of up and down. The pheos that I have seen, and I have seen many, been characterized by irregular behavior. That regularity, it's always down in the morning and up in the evening. Very unusual. Garry?
Yes, unless there's a particular trigger that's happening each day. Could I ask what time of day the catecholamine measurements were made in relation to the blood pressure?
They were made when the blood pressure was high.
Mm-hmm.
Mm-hmm.
And her husband did not put any urinary measurements on the urinary volume measurements on his spreadsheet, so we don't know about nocturnal diuresis.
No nighttime blood pressures either, I imagine.
The question was nighttime blood pressures. Have they been measured?
We only had the first morning pressures.
What time of the day does she take the Tizanidine?
Can you come to the microphone? We're filming this. Please don't spoil our film.
Aldo Peixoto, Yale. What is the time of the day that she takes the Tizanidine?
It was in the evening.
In the evening. Will you be discussing that? Okay.
So could a pheochromocytoma present with flushing? Dr. Garry alluded to the fact that these tumors can also produce other substances, including neuropeptides that would be vasodilator. And while this is quite rare, there is a beautiful picture in Ray Gifford's book on pheochromocytoma of a patient with a brilliant red flush and some periorbital edema. Looks very much like kind of flush that I've seen with bronchial carcinoid. So, but the exception proves the rule. Would you like to see further studies evaluating pheo?
Yes, please.
Okay. She had imaging of her abdomen and pelvis, CT with and without contrast, and there were no adrenal or periaortic masses seen. At this point, I'd like to ask my co-presenter to pick up the discussion.
One point is this is extreme labile hypertension with systolics bouncing up to 300 and then way down into the 80s. And it occurs suddenly. And it really reminds one of baroreceptor reflex inactivation with a lack of buffering of blood pressures. I don't know whether that's contributing to what's going on, but this would be a typical kind of labile hypertension in that setting.
We felt that this had a very strong hyperadrenergic flavor to the hypertension as well.
Any other comments from the audience? There are two. Dr. Burstein first.
I wonder how how blood pressure higher than 300 millimeters mercury was measured in a clinic. What instrument?
Good.
That was reported from an outside physician, but we don't have actual documentation of that. That was passed on by the patient, I believe. Dr. Oates might want to clarify.
I think the referring physician who measured this simply inferred that when the blood pressure cuff sits at 300, it's probably at or greater than that level.
So two clarifying questions about the comment on baroreflex failure. First, the pattern of evening hypertension, which is one that I cannot find in the literature. I know that people have observed. I have certainly observed, but it's a very common pattern in the way that this patient had. The second one has to do with the fact that she has hypothyroidism. So I just want to confirm that the hypothyroidism was not due to a total thyroidectomy with a full exploration of the neck, which would be probably one of the possible links.
It was not. She didn't have any history of neck surgery or radiation, which would be another key question when you're thinking about someone with baroreflex failure. I have several patients with baroreflex failure from radiation to the neck as well for thyroid cancer, but she did not have that history, did not have surgical intervention on the thyroid.
Let's move on.
All right. So we had a strong suspicion that medications could be contributing to the hyperadrenergic state that this patient had. This is a short list of considerations, sympathomimetics such as ephedra, pseudoephedrine, cocaine, even yohimbine has been reported that you can still get off the internet from supplement companies. Prescription drug withdrawal, and our suspicion was for clonidine or alpha-2 adrenergic agonist, or drug withdrawal from alcohol. And she had we questioned her about that. Dr. Oates questioned her about that, and she reported no history of exposure to any of these medicines or alcohol, and we had a low suspicion for any of these. So one of our participants has already suggested that Tizanidine, question the timing of Tizanidine, and she did take that once daily in the evening. And so we considered that to be one of the strongest considerations. So when we're thinking about clonidine-like agents, I've put the chemical structures up here so that you can see the similarities. Moxonidine is available in the European European physicians have access to this, but it's not prescribed or available in the U.S. In the United States, we have guanfacine. Dexmedetomidine is used principally in ICUs, not as an outpatient. And methyldopa is another alpha-2 agonist that's commonly used, and that Dr. Oates has a long history in describing the initial use of methyldopa for hypertension. But she wasn't taking any of these medications. But she was taking Xanaflex, which is referred to, Tizanidine is the generic name. Xanaflex is frequently what patients will refer to it as, is billed as a central muscle relaxant. It's an alpha-2 agonist. And so that's been mentioned or questioned the timing about when she took this by one of our participants. So we felt that Tizanidine could be contributing in this case. Tizanidine, compared to clonidine, has been described as a centrally acting muscle relaxant, whereas clonidine has been described as a centrally acting antihypertensive. Mm-hmm. But if you look at the package insert itself for Tizanidine, it's described in the package insert as an alpha-2 agonist at receptor sites and presumably reduces spasticity by increasing presynaptic inhibition at motor neurons. And they quote that they refer that it has no direct action on the skeletal muscle. So the principal muscle relaxant activity of Tizanidine appear to be central alpha-2 agonist activities. It's useful to review the pharmacology of Tizanidine compared to clonidine. The principal difference between the two drugs is the half-life of 2.5 hours for Tizanidine compared to a half-life reported to be 12 to 16 hours. These are taken directly from the package inserts from the manufacturers. They both have reasonable and similar bioavailability, and both undergo first-pass metabolism in the liver. And they also differ in their metabolism in that clonidine is both hepatically and renally cleared, but Tizanidine is principally and almost entirely cleared by CYP1A2 mechanisms in the liver. So we considered that Tizanidine rebound hypertension could be a cause of rebound hypertension in this patient. This would be very analogous to clonidine withdrawal hypertension, and so I've put a time course of blood pressure and plasma norepinephrine levels from a classic paper describing clonidine rebound hypertension. You can see that within 12 to 24 hours of the last clonidine dose, there's a peak in blood pressure and also a rise in plasma norepinephrine levels. So this would be similar to what we might be seeing in our patient. So going back to this is again the blood pressure trend, but this time I've highlighted the timing of when she would be taking Tizanidine. She took 12 milligrams at bedtime. And I'll point out that usually Tizanidine, because of its short half-life, is prescribed either 3 or 4 times a day. But we note that our patient took this only at bedtime. The reason she did this was due to drowsiness that occurred when she takes Tizanidine during the day. And that's a frequent description of Tizanidine use by patients, and they frequently select the timing to be at bedtime only. The usual dose is also 4 milligrams, where she was taking 12 milligrams at bedtime, which is quite a high dose for one dose. So our clinical suspicion was this was Tizanidine-induced daily rebound hypertension, and when thinking about potential ways to treat this, the suggested way to remove Tizanidine from the regimen is to taper it slowly by 2 milligrams a day, or to take it regularly 3 or 4 times a day rather than once a day. It's helpful also to replace Tizanidine in these cases with another alpha-2 agonist. So clonidine, methyldopa, or guanfacine in the United States would be options to give this patient. and less preferred would be possibly to use combined alpha and beta blockade. So here's the resolution of this case. The patient attempted to taper Tizanidine as an outpatient by reducing slowly the doses, but she continued to have severely high blood pressure at night associated with symptoms, and so she was brought into the hospital. She continued to have high blood pressure and low morning blood pressures in the hospital. She was treated with IV fluids for the hypotension, and additional antihypertensives were added. Clonidine was added while she was tapered off of Tizanidine in the hospital. So you can see this is the period that was shown previously, and up to the point that she was hospitalized, blood pressure during the hospitalization and after certainly became less labile and tended to be more controlled. Shown below is the lability of the blood pressure, so the peak minus the trough blood pressure within a day. So she had swings of 100 millimeters of mercury from the peak to the trough blood pressure. And you can say with the removal of Tizanidine, addition of clonidine and taper off of this, she had much less labile blood pressure after this drug was withdrawn. So to review some more on Tizanidine, it's similar to clonidine. It suppresses the sympathetic nervous system. And another fact is that can mimic autonomic failure. Our autonomic group, Dr. Biagioni and others have seen, I believe, similar autonomic failure cases from Tizanidine from patients that don't know that it can also cause this. I've mentioned before that patients self-select to dose only at bedtime, and this is primarily due to sedative effects. It can be abused by some patients due to these sedative and also has had reported to have hallucinatory effects. One other factor that's important is the drug interaction. So this may influence the side effects from the drug and potentially the rebound hypertension. And I mentioned that CYP1A2 inhibitors, or it's principally metabolized via CYP1A2, and so this makes it susceptible to CYP1A2 inhibitor interactions. This has actually been well described by a group, I believe in the Netherlands. Grandfors and colleagues have done several nice papers demonstrating the effect of potent CYP1A2 inhibitors, fluvoxamine and ciprofloxacin. So ciprofloxacin, much more commonly used, but fluvoxamine has a dramatic effect on drug exposure. There's a 33-fold increase in drug exposure with fluvoxamine. I've spoken with people in the clinical pharmacology division and have referred to this as possibly the largest drug interaction they've ever seen. Ciprofloxacin has about a 10-fold increase in drug exposure. And you can see that compared to the drug concentration curves, the actual therapeutic drug exposure is dwarfed by what happens during these drug exposures during CYP1A2 inhibition. And this actually has clinical ramifications on blood pressure. The blood pressure response corresponds quite well to the drug concentration and also the sedative effects. So blood pressure during co-administration of fluvoxamine or with ciprofloxacin produces much greater blood pressure reduction when co-administered with Tizanidine. And these are the best described and the most potent drug interactions, but there's a long list of other drugs that can interact with this medication that patients may also be taking. So very commonly used drugs like amiodarone, even over-the-counter medications that may not be reported, like cimetidine and famotidine, and other quinolones may interact with Tizanidine, but their interactions are less well described, so we don't know the effect for each of these. Also, estrogen or oral contraceptive pills also have an interaction that's been reported. Our group is led by Mike Steen and Cecilia Chung, have looked at whether this is impacts blood pressure in the hospital in patients that are taking Tizanidine as an outpatient, come into the hospital, and then are co-administered these CYP1A2 inhibitors. And they did find, by looking through the electronic medical record, that there is an increased incidence of either severe hypotension, low blood pressure, or a blood pressure drop in these patients. And they compared the blood pressure response to a controlled medication, such as cyclobenzaprine, which is another muscle relaxant that's not associated with alpha-2 effects. And they found that the risk was significantly higher with Tizanidine co-administered with CYP1A2 inhibitors. So this is a real-world effect that can be detected in a noisy electronic medical record. So the next question is who prescribes Tizanidine? So most likely this is given by primary care physicians because they're the largest number of prescribers. They prescribe the largest number of prescriptions in the United States. But there may be physicians or specialties that prescribe it more often than per prescriber than primary care physicians. And when you look at the CMS data, we found that there could be a reason that we're seeing this or we're reporting this is because it's more often prescribed here in the Southeast, and it's increasing over time. So you can see this is presented as a percent of all state prescriptions. The darker color would be a higher percentage of prescriptions. So it's slightly more often prescribed in the Southeast. And you can see from 2013 to 14, even 15 to 16, there's an increase so that we see this more often in the Southeast. And that may be why patients are referred to our clinic, and maybe we recognize it more often than other areas. We've seen this in other patients. We've presented and selected this case just to be illustrative, but we and my partners have seen multiple cases of similar presentations. So who is prescribing Tizanidine in the United States? If you look at Tizanidine prescription as a percentage of specialty prescriptions, patients that are physicians that are involved in pain management, chronic pain management, prescribe Tizanidine more often per number of as a percentage of prescriptions than other providers. So the top specialties here are pain management, anesthesiology, neurosurgery, which often they're involved in management of chronic pain. And in fact, our patient had received this prescription from a neurosurgeon. So in summary, Tizanidine may be the cause of rebound hypertension in patients, and we believe strongly that it was in our case. The principal reason in this case is that it was given at bedtime due to the sedative effects and taken in larger amounts, larger dose than should be taken. And the presentation is often with hyperadrenergic symptoms. CYP1A2 inhibitor drug interactions may precipitate severe hypertension, which may mimic autonomic failure as well, which I did not present today, but there are other presentations of that or reports of that. And Tizanidine is often prescribed by pain specialists as well as primary care physicians. And we're seeing this more often probably due to the alternative, to using it as an alternative to opioids. And so we believe that in the years going forward, we're going to see this more often due to the opioid epidemic in the United States. So rebound hypertension are likely to be seen more commonly. All right, and I believe we've got, Dr. Oates wanted to present one more case just after this, which is very short, 2 slides.
Okay.
So you might ask, are there other alpha-2 agonists out there waiting to surprise us in our clinical practice? So this is a patient who was 86 years old. She had renovascular hypertension that had been stented. Blood pressure was very well controlled on a triple drug regimen, but with small doses of the drugs. And then there was a phone call. The patient husband called. She had been at church, sitting down for a while, And then when she tried to stand up, she almost fainted, had to lie on the floor. And her blood pressure at that time was 72/57. And she was profoundly sedated for the rest of that day. The patient has borderline glaucoma. And that morning, after seeing her ophthalmologist, took for the first time, took a morning dose of the ocular brimonidine drops. And brimonidine is an alpha-2 agonist. And you can see what the result was. Supposedly selectively delivering a drug to the eye, but it runs down the lacrimal duct and becomes orally absorbed. And in a patient who's already on antihypertensive drugs, then the result that you see is the one that you would expect, is severe hypotension. It's probably worth pointing out that for both this drug and Tizanidine, the clinical trials that allowed FDA approval were done in individuals who were carefully selected not to be on antihypertensive drugs. And in those individuals, you'd be much less likely to see problems with hypotension. Thank you very much.
Thank you very much. We have a few minutes for audience comments, please.
Just while you're coming to the microphone, we've already discussed how extreme these blood pressure fluctuations were in this particular patient. Do you have any explanation for that beyond the very high dose she was taking?
The high dose combined with the once daily administration, I think, is the strongest predictor. I think it's a similar story that I've seen in a number of patients. I think I've seen this at least 5 or 6 times a year in new consults in the hypertension clinic, and my partners see this as well. And they all give a similar story. They're sedating, they take it at night, and then have labile blood pressure.
Okay, we have huge queue at the microphone. Please start.
Sandra Taylor, Mayo Clinic. So I'm troubled by the management of this patient. Once you figured out that she should be tapered off the Xanadex, the question is, how can you taper when you take a big dose at night? Why not just take her off because she's going into withdrawal daily, put her on a dose of clonidine, and then taper the clonidine over time? I feel like the problem was prolonged until she was put in the hospital.
You might be right in this case, and I think this was the first case that was recognized to be due to this. I frequently do exactly what you're saying. I'll replace Tizanidine with an alpha agonist, and I don't recall having other patients needing hospitalization.
She was hospitalized because of suspect of pheochromocytoma, and she was immediately put on clonidine and then taken off of the Tizanidine.
John
Okay.
and Matt, this was a very instructive case, and I think, as you point out, illustrates the potential problem with these agents, these kinds of agents. And whereas in the guideline, we were very careful to point out the problem with clonidine withdrawal, and not to use clonidine prior to surgery, because you might precipitate a hypertensive crisis during the surgery. We did not pay attention to these kinds of muscle relaxant drugs. It seems to me that there should be, if not a black box warning, at least a very prominent warning on this. I don't think it's appreciated in the primary care community or even in the hypertension community. So thank you for presenting this.
Charles Tift, Boston. I wonder if there's something else going on with the first patient. In fact, we don't know really how long she's had diabetes and that sort of thing, and whether she might have some component of autonomic dysfunction to begin with that would set her up for a much more violent problem with this drug withdrawal. And whether she's had any kind of autonomic studies afterwards.
Yeah, that's a good point. Right?
She had not had any further autonomic studies, but her blood pressures after she came off of these drugs were...
Mike.
Her blood pressures after she came off these drugs were did not demonstrate any orthostatic hypotension.
Okay, and the last or penultimate point.
Sure. Atul Chugh, Indianapolis from St. Francis Heart Center. Last month, I was asked to consult on a patient in the ICU, a 38-year-old female with hypotension requiring pressors for a second-degree Mobitz 2 block. The patient was presumably thought to have these issues secondary to some sort of sepsis. Turns out that she was surreptitiously using Tizanidine by hiding them in her bra. I guess the question is, have you seen, as the blood pressure goes, what have you seen with heart rate in these patients? And have you seen any sort of rebound tachycardia or any issues of tachyarrhythmias as well?
I haven't personally seen tachyarrhythmias, but the heart rate corresponds with the blood pressure. That's well described in the drug interaction studies, which are reported here. And it's in our autonomic failure group. They've personally reported to me. They also see, it looks just like autonomic failure with norepinephrine deficiency. I don't know about Mobitz 2 block or bradyarrhythmias or tachyarrhythmias, but you can certainly get hyperadrenergic rebound associated with all the arrhythmias that are similarly associated with that.
Okay, so last question for those of us who don't practice in United States. I have not come across this drug in United Kingdom. Is it prescribed elsewhere or is it a US special? Do you know? If not, we need to find out before we publish the paper, I think,
right.
because the journal reaches international audience.
That's a great question. I do know that it's not available in the EU, but I don't know about how many other countries this might be available in, so the audience might be able to
Garry?
help educate us.
Australia?
No, I don't know. I was heartened by some data you showed from Holland, which suggested it was being used elsewhere. But
they're at least aware of it.
Okay, last comment, please.
Two things. First of all, it is available in Canada, though I've not seen that effect from it, so thank you. The other question or comment, we talked a lot about autonomics. All the blood pressures, were they sitting? Was there ever supine? Was there ever an orthostatic blood pressure done to look at that?
These were seated home blood pressures recorded with the home blood pressure monitor by the husband and wife. She was documented to have orthostatic hypotension as well in the clinic and in the hospital, but those were not routinely done. I don't believe at home. Dr. Oates he knows the case originally.
Not at home.
Because when we think about the PM blood pressure, if we think about it from an ABPM, we think about it as a supine, right? But this would have been a sitting, so it would have been a bit different from that perspective.
Okay. Okay, I think the time has come to thank this team. This was a great presentation. Thank you very much. And